A 54-year-old woman is getting a carotid ultrasound as part of a stroke workup. The scan is clean, but the report mentioned something nobody was looking for, or a 1.6 cm solid, hypoechoic nodule in the right lobe of her thyroid, with microcalcifications. Her TSH is completely normal. She feels fine. What do you do next? If your instinct was to biopsy every nodule you find, or to reassure everyone and move on, pause. Because here is the tension that defines this entire topic: ultrasound finds a thyroid nodule in up to half of adults by age 60. Yet only 7 to 15% of those nodules are cancer. The job is not to find every nodule. The job is to find the few that matter, without overtreating the 90% that never will. In this video, we walk the full arc, the nodule workup, exactly the way the 2015 ATA guideline built it, and then thyroid cancer management, exactly the way the 2025 ATA guideline just rewrote it. Smaller surgery. Less radioactive iodine. Softer TSH targets. And a completely new strategy for cancers that stop taking up iodine. Every thyroid nodule workup starts with the same first step, and it is not the ultrasound. It is a TSH. Why? Because the TSH splits the road in two. If the TSH is subnormal, the next test is a radionuclide uptake scan. A nodule that is hyperfunctioning, hot on the scan, almost never harbors cancer, and per the guideline, it does not need cytology at all. You have just saved that patient a needle. If the TSH is normal or high, the ultrasound does the talking. And the 2015 ATA guideline gave us 5 sonographic patterns, a risk ladder that drives every decision that follows. At the top, the high suspicion pattern. A solid hypoechoic nodule with irregular or microlobulated margins, microcalcifications, a taller than wide shape, disrupted rim calcifications, or extrathyroidal extension. That pattern carries a 70 to 90% risk of malignancy. Below it, intermediate suspicion, hypoechoic and solid, but smooth margins and no bad features, 10 to 20%. Then low suspicion, isoechoic or hyperechoic, or partially cystic with eccentric solid areas, 5 to 10%. Very low, spongiform, under 3%. And purely cystic? Benign, under 1%. One more rule the boards love: sonographically suspicious neck lymph nodes get biopsied, regardless of what the nodule itself looks like. Before the needle decision, one more system, because it is the one your radiology report actually uses. The ACRTE-RADS, the American College of Radiology's Thyroid Imaging Reporting and Data System. Instead of pattern labels, it scores 5 features and adds the points. Composition, cystic or spongiform, 0 points, mixed, 1, solid, 2. Echogenicity, isoechoic or hyperechoic, 1 point, hypoechoic, 2, very hypoechoic, 3. Shape, wider than tall, 0, taller than wide, 3. Margins, smooth, 0, irregular or lobulated, 2, extrathyroidal extension, 3. An echogenic foci, the calcifications, none, 0, macrocalcifications, 1, rim calcifications, 2, punctate echogenic foci, the microcalcifications, 3. Add up everything that applies. The total sets the category. TR1, 0 points, benign, no FNA, ever. TR2, not suspicious, no FNA. TR3, mildly suspicious, biopsy at 2.5 centimeters. TR4, moderately suspicious, biopsy at 1.5 centimeters. TR5, 7 points or more, highly suspicious, biopsy at just 1 centimeter. Below those sizes, the answer is ultrasound follow-up instead of the needle. Now score our patient's nodule. Solid, 2 points. Hypoechoic, 2. Punctate microcalcifications, 3. That is 7 points. TR5, biopsy. The same answer the ATA high suspicion pattern gave us, a different road to get there. So TI-RADS gave you radiology's thresholds. The ATA guideline has its own, built on the 5 sonographic patterns from slide 2. Memorize this table too, the boards test it directly. High suspicion, FNA at 1 cm. Intermediate suspicion, also 1 cm. Low suspicion, wait for 1.5 cm. Very low suspicion, the spongiform nodules, 2 cm, and simply observing is a perfectly reasonable alternative. Purely cystic, no biopsy at all. And one exception worth pausing on, a suspicious nodule under 1 cm, no extrathyroidal extension, no suspicious nodes, can be watched with ultrasound rather than biopsied. Most micropapillary cancers are indolent. Needle restraint is sometimes the guideline correct answer. Now the needle comes back. Cytology is reported in the Bethesda system, 6 categories, 6 risk levels. Bethesda 1, non-diagnostic, risk 1 to 4%, repeat the FNA under ultrasound guidance. Bethesda 2, benign, 0 to 3%, follow with ultrasound. Bethesda 3, atypia of undetermined significance, 5 to 15%. Bethesda 4, follicular neoplasm, 15 to 30%, and here cytology hits a wall, because it cannot tell a follicular adenoma from a follicular carcinoma. That distinction needs capsular or vascular invasion, in other words, a surgical specimen. Bethesda 5, suspicious for malignancy, 60 to 75%. Bethesda 6, malignant, 97 to 99%, straight to surgical planning. Categories 3 and 4, the indeterminate middle, are where molecular testing earns its place. That is next. Bethesda 3 and 4 nodules are the gray zone, roughly 1 in 5 biopsies lands here, and most of them are still benign. Send everyone to surgery and you operate on a lot of healthy thyroids. This is exactly the problem molecular testing was built for, and there are 2 strategies running in opposite directions. Strategy 1, rule out. A gene expression classifier reads the expression pattern of the sample. A benign call drops the risk of cancer to about 5 to 6%, close enough to a Bethesda 2 that observation becomes reasonable. Strategy 2, rule in. A mutation panel hunts for specific drivers. Find BRAF V600E, a RET-PTC rearrangement, or PAX8P PAR gamma, and the risk of malignancy jumps above 95%. Manage it like cancer. A RAS mutation sits lower, around 84%, still very high, but it keeps a sliver of adenoma on the table. 2 cautions for the boards. First, molecular testing refines indeterminate cytology, it does not replace surgery for Bethesda 5 or 6. Second, if the negative panel does not make a suspicious ultrasound disappear. If the nodule looks like cancer and grows like cancer, tissue is still the answer. Now assume the biopsy came back malignant. What kind of cancer are you dealing with? Differentiated thyroid cancer means 2 main players. Papillary, about 80 to 85% of cases. It spreads through lymphatics to the neck nodes, it is driven by BRAF mutations in roughly half, and its prognosis is excellent. Follicular, 10 to 15%. A different beast, it travels through the blood to lung and bone, it is driven by RAS mutations and PAX8P PAR gamma rearrangements, and remember, its diagnosis required invasion, which is why cytology could never call it. The 2025 guideline now also treats oncocytic carcinoma as its own category, with its own behavior. Then there is staging, and the boards test the single biggest rule of AJCC 8th edition, age 55 is the dividing line. Under 55, a patient with differentiated thyroid cancer can only ever be stage 1 or stage 2, even with distant metastases, the ceiling is stage 2. Over 55, tumor size, extrathyroidal extension, nodes, and metastases push the stage higher. Moving from the 7th to the 8th edition downstage 20 to 30% of patients, prognosis in DTC is that age-dependent. One boundary before we go further, medullary thyroid cancer plays by completely different rules, different cell, different markers, different surgery. It is out of scope today and gets its own video. Here is where the 2025 guideline rewrites the playbook, starting with how much thyroid to remove. The rule is now size and spread, not fear. For a cancer 2 centimeters or smaller, confined to the thyroid, no clinical nodes, the initial operation is a lobectomy. That is a strong recommendation. For a low-risk cancer between 2 and 4 centimeters, lobectomy is still the preferred option. Total thyroidectomy becomes a choice you make for specific reasons, suspicious contralateral nodules, enabling radioactive iodine, or patient preference. Total thyroidectomy is reserved for tumors over 4 centimeters, gross extrathyroidal extension, clinically apparent nodes, or distant metastases. And for the smallest cancers, papillary microcarcinomas, clinical T1A, node-negative, active surveillance is now an explicitly acceptable alternative to operating at all. Underpinning all of this is the new 2025 risk stratification system. It no longer asks you to drop the patient into a rigid 3-tier box on histology alone. It weighs the pathology, the number of involved nodes, the AJCC stage, the postoperative imaging, and the serum thyroglobulin together, and it is designed to be updated as the response to therapy comes in. One more 2025 point that is pure board's gold: outcomes are better with high-volume thyroid surgeons, more than 25 to 50 thyroidectomies a year. Referring to one is now a strong recommendation. Radioactive iodine is not one treatment, it is 3, and the 2025 guideline wants you to name which one you are ordering. Remnant ablation: destroy the benign thyroid tissue left after total thyroidectomy so that thyroglobulin and scans become clean surveillance tools. Adjuvant therapy: mop up microscopic disease you cannot see, to lower the risk of recurrence. And therapy of known disease: treat residual or metastatic cancer you can actually measure. So who gets it? The 2025 answer is far more restrained than a decade ago. ATA low-risk patients after total thyroidectomy, remnant ablation is not recommended routinely, a strong recommendation with high certainty evidence. Intermediate risk, RAI may be considered, this is where the postoperative thyroglobulin and the response to surgery tip the scale. High risk, adjuvant therapy is recommended routinely. And any patient diagnosed with distant metastases, RAI therapy is recommended routinely. Preparation has its own rules. Recombinant TSH stimulation is now preferred over hormone withdrawal for remnant ablation or adjuvant therapy. If you do withdraw, levothyroxine comes off for 3 to 4 weeks, the goal is a TSH above 30. Add a low iodine diet for 1 to 2 weeks, under 50 micrograms a day, and always ask about iodinated contrast in the last 3 months and amiodarone, because either one can render the treatment useless. And never forget, pregnancy test before RAI in women of reproductive age, no RAI while breastfeeding, and no pregnancy for at least 6 months afterward. Differentiated thyroid cancer cells keep the TSH receptor on their surface. TSH tells them to grow and to make thyroglobulin. That is the entire logic of TSH suppression: enough levothyroxine to push TSH down and starve the cancer of its growth signal. The old reflex was to suppress everyone, hard, forever. The 2025 guideline explicitly breaks that reflex. Suppression below the reference range is now individualized. Patients with high-risk disease are the ones most likely to benefit. And for low or intermediate risk patients who show no biochemical or structural evidence of recurrence, long-term suppression is not suggested. Period. Why the retreat? Because suppression is not free. A chronically suppressed TSH buys you atrial fibrillation and accelerates bone loss, and the patients paying that price are often older women with the most indolent cancers who had the least to gain. The harm was real, the benefit, for low-risk disease, was never proven. So the modern pattern: match the TSH target to the risk and to the response. High risk or incomplete response, keep it suppressed. Excellent response in a low-risk patient, let it drift back into the normal range, and re-evaluate over time as the response categories evolve. TSH suppression is a dial, not a switch, and in 2025, the default position of that dial has moved. Treatment is the beginning. Surveillance is where thyroid cancer is actually managed, and the 2025 guideline organizes it around one idea: the response to therapy. The tools first. A serum thyroglobulin, drawn 6 to 12 weeks after total thyroidectomy, on thyroid hormone or after stimulation is the early compass, an undetectable TG on a sensitive assay, without TG antibodies, after a clean neck ultrasound, is exactly what you want to see before deciding on RAI. After a lobectomy, a single TG with a normal TSH, just to confirm it is not unexpectedly high. Then a neck ultrasound at 6 to 12 months, looking at the thyroid bed and the central and lateral nodes, with the interval after that set by risk and response. Found a suspicious node? Size rules again, 8 to 10 mm or more, biopsy it, and send the needle washout for thyroglobulin. Smaller than that, watch it, unless it grows or threatens a vital structure. Now the 4 categories that run everything. Excellent response, no biochemical or structural evidence of disease, de-escalate. Indeterminate response, non-specific findings, mildly elevated or falling antibodies, most of these patients do fine, keep watching. Biochemical incomplete, abnormal TG or rising TG-AB, but nothing on imaging, chase it with cross-sectional imaging of lung and bone, not blind treatment. Structural incomplete, disease you can see, now you act. The point the boards test, this system is dynamic. An intermediate risk patient who responds beautifully gets reclassified, and the intensity of everything, from TSH targets to scan frequency, follows the response, not the initial label. What happens when the cancer stops listening to radioactive iodine? First, definitions, because you cannot call a cancer RAI-refractory before it has actually been given a therapeutic dose. The 2 strong criteria, no iodine uptake on a post-therapy scan despite disease you can see on imaging, or progression within 6 months of a treatment dose that did show uptake. Once a patient is truly refractory, do not keep giving empiric RAI. The guideline is blunt, other treatment should be considered. And before any systemic therapy for progressive disease, test the tumor for actionable drivers, ENTRAC and RET fusions, BRAF mutations, because several now have approved, genotype-matched drugs. But here is the newest idea in the field, redifferentiation. Why do these cancers lose iodine uptake in the first place? An overactive MAP kinase pathway silences the genes that make a thyroid cell, including the sodium iodide symporter, the protein that pulls iodine in. Block that pathway, and the gene expression switches back on. The cancer remembers what it was. The proof of concept, salometinib, AMEK inhibitor, restored uptake in 12 of 20 refractory patients, and the biology mattered. All 5 NRAS mutant patients responded, only 1 of 9 BRAF mutant patients did. Combine BRAF plus MEK blockade, dabrafenib and trametinib in the Meriode trial, and 20 of 21 patients redifferentiated, with a 38% partial response rate at 6 months. The 2025 guidelines verdict, redifferentiation may be considered in selected patients with targetable mutations, clinical trials encouraged, but it is not recommended as routine adjuvant therapy in unselected patients. Precision, not empiricism. Let us land the plane with what changed in 2025, because the boards and your attendings will test the delta, not just the baseline. 1. Surgery shrank. Lobectomy is now the default for confined cancers up to 2 cm, and the preferred option even for low-risk tumors up to 4. 2. Radioactive iodine got rationed. Not routine in low-risk disease, full stop. 3. TSH suppression softened. Low and intermediate risk patients with an excellent response go back to the normal range. 4. Active surveillance became a legitimate front door option for papillary microcarcinoma. 5. Management became dynamic. The response to therapy, not the initial risk label, now drives every downstream decision. When do you refer? Compressive symptoms or rapid growth? Hoarseness, that is the recurrent laryngeal nerve until proven otherwise. A fixed, hard mass. Any sonographically suspicious lymph node. Childhood radiation exposure. And a family history that suggests a syndrome, 2 or more first-degree relatives should make you think beyond sporadic disease. And the 3 classic board traps. Do not biopsy a hyperfunctioning nodule. Hot nodules almost never harbor cancer. Do not expect cytology to separate follicular adenoma from carcinoma. That call needs a capsule. And do not suppress TSH forever in a low-risk patient who is doing beautifully. You are treating their bones and their heart, not their cancer. Back to our 54-year-old with the incidental 1.6 cm nodule. Solid, hypoechoic, microcalcifications, a high suspicion pattern. Her TSH is normal, so no uptake scan. This nodule meets criteria for FNA, a high suspicion, over 1 cm. Cytology comes back Bethesda 6, papillary thyroid cancer. Neck ultrasound shows no suspicious nodes. Now the 2025 logic. A confined cancer under 2 cm, node negative, lobectomy. Not a total thyroidectomy. Final pathology confirms low risk, no radioactive iodine, not routinely. No lifelong TSH suppression, normal range is the target. Instead, she gets a post-operative thyroglobulin, a neck ultrasound at 6 to 12 months, and a care plan that escalates only if her response to therapy says so. 10 years ago, she would have lost her whole thyroid, taken the radiation, and lived suppressed. In 2025, she keeps half her gland and, most likely, never hears from this cancer again. 3 takeaways. 1. TSH first, ultrasound pattern second, FNA only above the pattern-specific size, the order is the answer. 2. 2025 is the era of de-escalation, smaller surgery, less RAI, softer TSH targets, and management that follows the response to therapy. 3. When iodine stops working, test the tumor. Redifferentiation is turning RAI-refractory cancer back into RAI-responsive cancer. Practice cases like this at medboardpro.org and subscribe for evidence-based clinical education.